you going, guys? My name's Simon.
My name is Terry.
Welcome to our presentation on haematology, mainly focusing on haemophilia and von Willebrand disease.
Now, what I'm going to be starting off today is about blood, so the basics. Blood is an important body fluid that helps carry substances throughout the body. It carries substances such as oxygen and nutrients around to its cells and also carries away metabolic waste. Blood is comprised of plasma, blood cells, red blood cells, white blood cells, and platelets. These all carry out their function in the blood, especially in the process of healing. When there is damage to a blood vessel, hemostasis occurs. Now, the first stage of hemostasis is inflammation, where heating and swelling occurs, as well as the clotting of platelets, and platelets control bleeding. In this phase, there are cases where the clotting in the inflammation stage is not effective. When this happens, the bleeding time extends to a longer period of time and is known as the condition haemophilia. Haemophilia is a bleeding disorder and is inherited through genetics, though mostly males suffer from this condition because of it being X-linked recessive disorder. This is due to haemophilia obviously being X-linked recessive. Most cases appear with a family history of haemophilia, whilst 1/3 appear with no history. This is because of the reduced levels of clotting factor prolongs the bleeding duration, as well as the process of healing. The clotting factor in blood are proteins that work together to stop the bleeding. These proteins are made in the liver and are distributed in the blood. The clotting proteins that affect the haemophilia are the clotting proteins 8, so VIII, and IX9. These are directly related to the haemophilia condition A and B, respectively. There are 3 different types of haemophilia in total, being haemophilia A, B, and C. Haemophilia A is the most common form of haemophilia to come across. Haemophilia B, Christmas disease, is also an X-linked gene disorder similar to haemophilia A, but not as common. Haemophilia C is different in the way that only one parent containing the haemophilia gene is needed to pass down to the next generation. But haemophilia C also has a different clotting factor, being clotting factor 11, XI. Now, the Von Willebrand disease is also related in its ability to effectively clot because of a deficiency in a Von Willebrand factor, similar to the other types of haemophilia. The Von Willebrand disease comprises of 3 subtypes: type 1, type 2, and type 3. These are categorized from mild to severe, where type 1 is more common, but the factor works normally, it's just the quantity of the factor lacks. Type 2 has even more subtypes within it, being type 2A, 2B, 2M, and 2N, where all of them have a sufficient amount of factor, but the factor does not function as normally. Lastly, type 3 is the least common type, showing patients with no factor or little of it. This can cause severe bleeding and leak blood into other areas. All these conditions affect the process of hemostasis. Now, hemostasis, as I said before, can stop and control bleeding. Inflammation, where the blood vessels constrict to limit blood flow, and the platelet aggregation occurs. Now, this happens where the platelets clump together around the hole after the initiation of endothelial cells secreting proteins, alarming that there has been an injury. To initiate the platelets to come together, platelets have receptors that bind to Von Willebrand factor using platelet adhesion. Platelets then clump up using the ligand receptor system, binding on a platelet-specific receptor. It also binds to the factor VIII from being broken down so it can be used to fuel the cycle again. This process is the primary stage of hemostasis, where the blood vessel constricts and also the creation of the platelet plug. Now, the secondary part of hemostasis starts where fibrin, also named as protein 1A, is added to the plug to solidify the current platelet plug. This occurs when fibrinogen is activated to then activate fibrin to solidify the plug. But before that happens, thrombin activates fibrinogen and prothrombin activates thrombin. And in this chain, there's an even larger system. There are two pathways towards this system. There's an intrinsic and extrinsic pathway that are vital to activating thrombin to then fibrin to form the clot. This is initiated from a tissue factor in the extrinsic pathway and platelet in the intrinsic pathway. Both pathways converge into one after a series of activations and the clotting factors. It leads to factor X, continuing to prothrombin, and of course, eventually to fibrin. These pathways consist of clotting factor proteins 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1 that assist with structuring a secure clot. These all are created inside the liver and again distributed into the blood. When the fibrin is activated, they combine together to create a strand that is used to create the secure layer of the plug. Multiple strands are aligned together and are cross-linked to make the mesh-type surface. This is the process of hemostasis before the clot is able to heal the damaged vessel and reverse the mechanism. This is called the coagulation cascade. Now, how haemophilia and von Willebrand affect this process is in its chain of activation. How haemophilia A has a factor V8, factor 8, haemophilia B's factor 9, and haemophilia's factor 11 are all included in the intrinsic pathway of the cascade. A deficiency of these factors decreases the amount of factors getting activated and eventually reduces the amount of fibrin produced to stabilize the clot. In addition to the bleeding, it can leak into other tissue areas and cause mortality through blood increasing the intracranial bleeding and can cause death, which is one of the examples. One of the many problems patients suffer from is joint bleeding. It can also cause many mobility issues and countless treatments. Now, in von Willebrand's disease, the primary stage of hemostasis is disrupted, where platelet adhesion in the primary stage of hemostasis is not as effective. And of course, the bleeding duration is extended. It also holds the protection of factor 8, preventing it from being broken down.
Now we'll talk about haemophilia victims and how common we will meet them in the field. Haemophilia victims suffer from the inability, as we know. Consequently, they often don't know where the bleeding comes from because they have little cuts and then they just keep bleeding. Often those who suffer from haemophilia are often left with uncontrolled bleeding as their body cannot control the site. Paramedics in Australia will not likely come across those with haemophilia, as only 1 to about in 6,000 to 10,000 males, or roughly in Australia 2,800 alone, suffer from its effect. In the case we do encounter patients with these disorders, we should treat them as a hemorrhaging patient. They should try to control the site of bleeding, and if they are unable to control the site, then treat as per uncontrolled hemorrhage guidelines. Now, if we do need to give any sort of pain relief, intravenous access may be performed, but only when absolutely necessary due to opening a site and potentially causing any bleeding. Now, alternative pain relief such as intranasal fentanyl or methoxyflurane could be used instead of any IV opioids. In some cases of fluid replacement may take priority due to the severe blood loss. In that case, it takes precedence. In the case where any uncontrolled hemorrhages is determined, immediate transport is recommended due to the limited pre-hospital treatment that can be given. Now that can be found in special notes of the Ambulance Victoria CPG. Now the best possible outcome for these patients is obviously to transport them into emergency care where appropriate prophylaxis can be given. Hemophylactics who incur or have reported internal trauma must be treated as severe and critically emergent, as their bleeding must be considered uncontrolled. For example, traumatic head injuries and central nervous system damages are to be considered medical emergencies and must be dealt with immediately due to potential manifestation of intracranial and spinal hemorrhage. Following MRI and CT scans must be done, also blood tests, so that they'll know if there's any internal bleeding. Internal hemorrhage must be the priority, as the unknown bleeding may result in severe hemorrhage and thus consequently leading to hypoxia and potentially the end result of ischemia, which could lead to dangerously low hemoglobin levels and causing death. The prophylaxis of choice in modern emergency care includes the usage of factor 8 or factor 9 recombinant products. This is used to correct the initial factor 8 and factor 9 deficiency in the patient, which helps occlude blood. Recombinant 8 concentrates are the treatment of choice for haemophilia A, whereas recombinant factor 9 are the treatment of choice for haemophilia B. Risk of viral infection is possible, but during the infusion of treatment, they do try to exclude it by having a technique in the way they develop the prophylaxis. It will reduce the possibility of contracting against lipid encapsulated viruses such as HIV, but it's still being worked on as it could still potentially manifest. Von Willebrand disease is another bleeding disorder which is hereditary inherited. Those who do not suffer from Von Willebrand disease have a type of protein. Now the protein is called the Von Willebrand factor. Obviously those who do suffer from it don't have the VWF, and consequently this reduces the time for blood clotting, and also increases the amount of hemorrhage. Von Willebrand disease is believed to be the most common bleeding disorder in Australia. Paramedics are likely to come across them, as it is believed to be about approximately 200,000 people in Australia who suffer from it. Now, only about 2,000 people are diagnosed, so this suggests many have yet to be diagnosed and thus do not know they have the disorder. Now, this is significantly dangerous and concerning, as it is quite moderate in nature as compared to the different types of haemophilias. It could be potentially dangerous due to the amount of blood loss if not careful. Now, should paramedics come across any patient who displays signs or symptoms of Von Willebrand disease, they should be treated carefully and managed the same way as a haemophiliac. Hemorrhage control should be the first priority. Should it fail to be controlled, the best option is to transport immediately. If pain relief is required, then again, non-invasive techniques should be tried. Again, intranasal fentanyl will be the most preferential in cases like these. Now, the treatment of choice with von Willebrand disease mainly includes high purity von Willebrand factor concentrates or recombinant 8 concentrates in emergency care. Now, pre-hospital ambulance services in Victoria do not have these specific prophylaxis. In conclusion, patients with haemophilia or von Willebrand disease should have their bleeding controlled if possible. If not, the next best option is to transport. Transporting the patient in some cases could be detrimental to the survival, as in severe cases could lead to patient losing too much blood and consequently their lives. In those cases, by transporting the patient to emergency care, you will be giving the patient the best chance of survival, as in hospital treatment